Okay, good morning. My name is Santiago Palacio. I'm the stroke fellow at the University of Texas Health Science Center. And today we will discuss mainly topics relating to primary stroke prevention. So we're going to talk about patients who never have symptoms of cerebrovascular disease. And I will focus part of my presentation on hypertension, which was the topic assigned to me. As a handout that I brought to you, this is an article published in January 2001 in Circulation, which sort of summarizes some of the topics we are going to discuss. And I think that it would be for your interest because it has an update of all primary prevention in stroke. So even though we're going to talk especially about hypertension, it has recommendation for the American Heart Association based on different level of evidence, as you will see, from randomized control trials, which are the strong evidence, to case controls or case series, which are the weakest evidence. So before we start, let's first try to focus on the topic of stroke and the magnitude of the problem. As you can see, this is data from 1994, but stroke is actually the third leading cause of death after cancer and heart disease, and is the first leading cause of disability. This is, as I told you before, this is data from 1994. Now the incidence is actually 700,000 cases per year, and the cost is almost rising like $50 billion per year. And the other problem is that most of stroke patients are at risk of recurrence of stroke, which is the main message I want to bring you, that most of these strokes can be prevented. Okay, so that is an important issue. And even though the incidence of stroke has been declining in the last 20 years, mainly because we have new treatments like TPA for the acute stage of stroke, the actual incidence is increasing. This is because the age group which is most vulnerable to stroke is increasing. So we have between the age 55 and over is an age group which is increasing in the United States. So that's why, even though there are some therapeutics approach that help, the actual incidence is increasing. Well, how can this be translated in economic issues? Even though there are different subtypes of strokes, each one with different levels of disability, we can make an average, like the average lifetime cost of stroke is estimated to be around $60,000. So you can imagine how important prevention is when we look at these numbers. Okay, another important concept I want to remark is that stroke shouldn't be seen like a unique disease with only one pathophysiology, but it has to be seen as a syndrome caused by different causes, each with different treatments, with different pathophysiology, and with different prognosis. As we see here, 80% of the strokes are ischemic strokes, so they are caused mainly by blocking of arteries. Okay, that's the main mechanism. And 15% are hemorrhagic strokes. Okay, whenever the artery bleeds. Okay, we will see later on that hypertension is an important risk factor for both ischemic and hemorrhagic strokes. Okay. 60% of these strokes are due to cerebrovascular disease. 20% is because of penetrating disease, is what is called small vessel disease. Here, hypertension again is a big problem. Between 15 and 20% are due to cardioembolism. This seems to increase as the improvement of new techniques like transesophageal echocardiogram is being used. So we are starting to find another potential sources of cardioembolism. And 5% of the cases, there are other etiologies like hypercoagulate states, dissections, and less prevalent causes of stroke. Well, this is just a diagram to show you whenever we have, we are talking now about ischemic strokes, how important it is to think about different pathophysiology, but because that will change dramatically our management. For example, in this diagram, we have first different sources of embolism. You can see here, for example, in the heart, atrial fibrillation is the leading cause of cardioembolic strokes. So most patients who can tolerate will be candidates for anticoagulation with warfarin. For example, if we go up in the aortic arch, we will see that, for example, aortic atheroma is increasingly looked as a new potential cause of embolism. So this source is actively now being investigated. Again, if we go up, it's not the topic of this discussion, but just to remind you that whenever you have extracranial carotid disease, for patients who are symptomatic and have more than 70%, endarterectomy is the treatment choice. As a matter of fact, there has been a publication a month ago from the NACET, which encourages, which did an analysis of patients over 80 years old, and the result was that this age group benefits the most with carotid endarterectomy. So that's another message I want to give you. So to encourage, age shouldn't be a contraindication to have carotid endarterectomy. So this is, and we don't still, another sources of ischemia can be diseases of the penetrating or the small vessel disease, which are the ones who produce the lacunar strokes, tiny strokes less than 2 centimeters, which have again a different pathophysiology for extracranial disease. I would say that now we have effective treatment for cardioembolic strokes with warfarin. We have effective treatment for extracranial artery disease, and there are still remaining questions about intracranial disease and lacunar disease. These are topics which up to now we don't have a clear aspects in terms of the management, and mainly instead of in management. Okay. Well, this is again to remind you, whenever we are talking about atherothrombosis, atherothrombotic strokes, the different causes, this could be produced either by narrowing of the intracranial arteries or by emboli artery to artery. Okay. Well, so now we will focus on the risk factors of cerebrovascular disease. As you know, there are risk factors which are modifiable and non-modifiable. Okay, the non-modifiable risk factors are age, sex, race, and ethnicity. In respect of age, you have to know that after the age of 55 years old, the stroke risk increase doubles each decade. So even though it's not a modifiable risk factor, it's an important and preponderant risk factor. In respect of sex, men are more affected than women, and in terms of ethnicity, we will see in a few minutes, but African Americans and Mexican Americans are more affected than whites, and we will see that the distribution of the etiopathogenesis of the stroke varies between races. As you see here, the most preponderant and prevalent risk factor apart from age is hypertension, which increases the risk by five times the relative risk. And then we have smoking, diabetes, hyperlipidemia, and obesity, which more or less increases the risk by 2 in comparison to people who don't have these risk factors. Okay, as I told you before, race and stroke risk is different between the populations. African Americans they have increased risk of stroke in comparison from whites. This is mainly because of the higher incidence of hypertension and diabetes in African Americans. So that's why it's part of the explanation why African Americans are more affected. And I think that a topic that is interesting for us because of our population here, that up a third of our population in Texas are Hispanic Americans. We see that we have a different profile in the stroke distribution. They are usually younger, and they are usually more affected by lacunar strokes. So strokes, tiny strokes that produce lacunar syndromes. So I think this is an important topic we have to take in account whenever we are talking about Mexican Americans. This is an interesting situation comparing here you have the geographic variation in stroke incidence. This is what is called the stroke belt. As you see in red, you will see that those states that are highlighted in red are the states with a higher incidence this is an example in black men, but it's also in other races. And we see that the incidence of strokes in these areas is increasing in comparison to other areas of the country. So even though there are mechanisms like hypertension, heredity, and diabetes, there must be something environmental there that also is causing this increase in the incidence in comparison to other areas. Well, this is another diagram I think that's interesting in terms to comparison, as I told you before, Mexican Americans and whites. You will see that the distribution of strokes is different in these two populations. As you can see, Mexican Americans in comparison to white have a greater incidence, as I told you before, of lacunar strokes and intracranial hemorrhages in comparison to whites. Okay. One explanation for this is because Mexican Americans have higher prevalence of hypertension and diabetes, and it has been shown that whites have, mainly when they are in the 70s and 80s, they have more prevalence of atrial fibrillation. So that's the main. So you have to keep in mind these two different profiles in stroke tendencies. Okay, let's talk first about diabetes. Several prospective cohorts and case control studies have shown that diabetes increases the risk of stroke. People with diabetes have 2 times more probability of having a stroke than normal persons. Also, they have associated, the mechanisms are variable, but another point that makes this also prevalent is because diabetics tend to have more hypertension than normal people. And the strokes also affect diabetics at a younger age, so that's important in order to prevent strokes in younger people. And once stroke has happened, the incidence or the rate of death is 2 times higher than in non-diabetics. And also, as you see, the recovery is less complete. Okay, let's talk about smoking and risk of stroke. Here you have a diagram, both men and women, and you can see that the risk of strokes increases with the number of cigarettes per day. This source is from the Framingham cohort study. So it shows you that on average, the most, with increasing number of cigarettes, how in both men and women the risk of strokes increases. The mechanism by which smoking increases the risk of strokes is not unique. There are some changes in fibrinogen. There are they promote the increase in LDL, so there is no unique mechanism. It's a multifactorial mechanism. And this is interesting in terms to show, this is we have there three different curves, okay? You will see the lower one is in smokers, and the upper one we have non-smokers and former smokers, okay? Both in men and in women. And the interesting thing about this, and that's why we should encourage our patients and we should screen our patients about smoking, is that, for example, the Framingham cohort found that after 5 years, the risk of stroke in former smokers goes almost the same as non-smokers. So I think that that's a remarkable and interesting point to say that after 5 years, even though former smokers diminish and they equal the risk of strokes as smokers. Well, what about cholesterol and stroke? Well, this has been, in the last 10 years, this has been a controversial issue because several studies show that lowering cholesterol diminishes the risk of having myocardial disease or cardiac disease, but none of these studies didn't show a real stroke risk reduction. So this was like controversy, or it was surprising for one point of view, because even though the study did show risk reduction in myocardial infarction and cardiac disease, there was not the same about strokes. But this is a study until the statins, until the group of statins appeared. This is one example I want to show you from the evidence of this. This was the Scandinavian statin survival study, which showed that lowering cholesterol not only decreased the risk of myocardial infarction and cardiac disease, but also it produced a stroke risk reduction, a non-cardioembolic stroke risk reduction. So this was the first study to show that people with high LDL cholesterol should be treated, and that helps in stroke prevention. Okay. We are talking only about patients with low risk. There are several studies underway trying to find out patients with only cerebrovascular disease. Mainly of these studies become from patients with myocardial disease. Okay, but now are underway several studies trying to find out if patients with cerebrovascular disease benefit from lipid lowering approaches. This is another study which also showed which may be the mechanism by which lowering high cholesterol and LDL may help in stroke prevention. This was a study which was done in patients with asymptomatic carotid disease, okay, by sonogram. They did a sonogram, and at the same time they found asymptomatic carotid disease, and they have, as an inclusion criteria, they have to have an elevated cholesterol level, LDL level. So they were treated either by statins, lovastatin, or placebo, and they were followed serially with carotid sonograms. And what they found is that the patient treated with statins showed a decrease in the plaque formation. Okay, so they concluded that lovastatin reverses the progression of carotid plaque in patients in asymptomatic patient. So that's another part of the evidence which shows that lowering cholesterol may have not only an effect apart from lowering the LDL, it may also stabilize the plaque, and there are other theories that say they may have also an anti-inflammatory effect. So, well, as I told you before, after the result of these studies, They say that in patients with myocardial disease, myocardial infarction or angina, the statins reduce more or less like 30% the risk of stroke. Okay, they have they produce a reverse in the progression of the plaque, and should be advised in people with coronary artery disease and with elevated cholesterol. For cerebrovascular disease only, things should be addressed in the future with the result of ongoing trials. Well, now let's focus on hypertension, which is the main topic today. As I told you before, apart from age, hypertension is the most prevalent risk factor, and we see this is data from 1983 that the prevalence increases sharply with age, 30% more than 18 years old, and then it goes up 53% between the age of 55 and 64, and it reaches up 64 after the age of between 65 years old. So it's a very prevalent disease. Where does the evidence that hypertension come from? This was for a long time isolated systolic hypertension was not considered a risk factor for stroke until a couple of years ago that it was found. This was a pivotal study, was the systolic hypertension in elderly program. So basically this study was to randomize patients. It was a stepwise program in which patients were randomized either for placebo or hypertension, and in 2 steps, first to treat the patients with hydrochlorothiazide or chlorthalidone, and then with a diuretic, and then for 4 weeks, and if they didn't improve, to add a beta blocker. So this was the first study to address this issue about systolic hypertension in the elderly. So what did they found? This diagram showed that in a 4-year follow-up, they could achieve a diminution in 13 millimeters of systolic hyperpressure, you can see in the upper part, and between 3 and 4 millimeters in the diastolic blood pressure, using this step approach of a diuretic and then a beta blocker. How this translated in terms of in risk reduction? Well, as can you see in this diagram, look at the placebo in the upper line, the pink one, and look at the patients treated with the step treatment. They reach more than 30% risk reduction. So this pivotal trial, along with another one which was done in Europe at the same time, which was called the System-Audie trial, showed that hypertension in the elderly and systolic hypertension in the elderly is an important issue and should be treated. This is another diagram which shows you another trials that also were treating elderly patients, and you see that most of them showed a risk reduction, a stroke risk reduction on average between 30 and 40%, which emphasizes the importance of treating patients with isolated systolic hypertension. Well, once we have established and we have this evidence, who patients should be treated? Well, obviously patients with more than 140 milligrams and or diastolic 90 milligrams, especially if they have end organ damage or other cerebrovascular risk factors. Well, before starting with the medical management, we have to work on trying to change some lifestyle modifications. such as regular exercise. The American Heart Association is recommending 30 minutes per day of moderate exercise. Weight reduction, even though weight reduction is not associated with is not an independent risk factor for stroke, it has comorbid conditions like hypertension and diabetes. So this should also be encouraged. Dietary modification and moderation of alcohol intake. Even though it's hard to recommend for no drinkers to drink alcohol, but it has shown that less than patients should be encouraged to drink less than 2 drinks per day. Okay. Well, in terms of the goal of blood pressure, as I told you before, for most patients, 140, less than 140 and less than 90 should be the goal. But there is emerging evidence that for another patients, we should go lower, because it seems that the lower the better. These patients are mainly diabetics, which now the recommendations are to lower the blood pressure less than 135 over 85. And in African Americans, it seems like also a lower level of blood pressure achievement would diminish the risk of stroke. So it's increasing evidence that, as we were taught some years ago, that we should go over 140 of systolic, less than 140. Now there is increasing evidence that maybe the lower the better. Well, which are our medications we have up to now in order to achieve these goals? Well, we have several approaches. Beta blockers and diuretics are usually recommended as the first line at the first step in hypertension management. And when these fail, we can add another of the second line medications, taking into account the personal or the history, individual history of each patient. That will help us to decide which medication to add or which medications to start. But there are some of these medications that recent randomized trials have shown that are benefit in certain disease. That's what I will show you in a couple of minutes. As I told you, there are patients with certain disease that benefit more from some hypertensives than others. Recent results from randomized trials have shown that diabetics benefit with proteinuria benefit more from ACE inhibitors. So those should be the first line medication to take in diabetics. Also, patients with insulin resistance will benefit more for ACE inhibitors. The use of low dose diuretics reduces the drug related side effects. And beta blockers, whenever after an infarction, they reduce death and reinfarction. And diuretics and beta blockers may aggravate diabetes. So we have enough evidence to say that there are certain populations that benefit with with certain medications more than others. Okay, so which would be our approach in primary prevention as a summary in patients in elderly hypertensive in comparison to other patients? Well, first, it's an important remark to do that the reducing initial in blood pressure should be in a step way. We cannot do it as we do with other people because we may induce orthostatic hypertension in this population. It's worthwhile to see this patient every 2 to 4 weeks to monitor how the blood pressure is doing, and after blood pressure is achieved, to control then each 3 or 4 months. Okay. And this is just the conclusion, and I want to show you this is a pilot study that we're doing now here at the University of Texas Health Science Center. This is not primary prevention, but secondary prevention of small subcortical strokes. It's called SPS3, and I think that would be of your interest because we are including patients with only small vessel disease. As I told you before, this is an issue that has not been addressed yet. So we are including patients only with small vessel disease, no extracranial disease, no cardiac disease. We are excluding all disorders, so we are concentrating only on patients with small vessel disease. I can tell you after including more than 60 patients that the prevalence of diabetic, most of these are Mexican Americans, and the prevalence of diabetics and hypertension is very high. So we are doing the design of this pilot study is a factorial design. We will randomize patients to have 2 active treatments and 2 antiplatelet treatments, which would be aspirin, which is the only known treatment now in order to prevent to secondary prevention. And we are going to, the other arm would be aspirin plus clopidogrel. These 2 antiplatelets, in theory, would work in different way in order to prevent strokes. The mechanism of these antiplatelets are different, so we are thinking that may be potentiate the effect of each therapy. And in terms of the hypertension arm, which I think is interesting for you, we are randomized patients from 2 groups also. One group between 130, over 130, and one group less than 130. So as you can see, and as I told you before, there is increased evidence that lowering the blood pressure below levels that we were used to tend to prevent more cerebrovascular disease. So hopefully this pilot will be submitted for a grant, and maybe we will do the multicentric study. So as a conclusion, I would say, well, the main things in the last years have been the recognition of isolated hypertension as a risk factor of stroke. This was not recognized before, but patients should, I think we should encourage in our elder patients to try to treat systolic hypertension. The approaches, the medication should be in a step way, started with diuretics or beta blockers, and then individualized. There is no one scheme of antihypertensive medication in our patient. We have to see comorbid situations in order to choose our best therapy. And there is also increasing evidence that is showing that decreasing also the blood pressure, the systolic blood pressure depression, is retarding signs of mild cognitive impairment or dementia. So I think that would be my message for you. These people should be treated the best way possible, because the evidence is strong that if we keep this patient with low blood pressure, the benefits outgrow largely the harm. Okay, thank you very much. Is there any questions?
Thank you.
Okay.
He must know something, but don't